Hi there and welcome to Lorena's Labyrinth. This video today is part one of a series looking at the physiology of what some people call mental illness. Mental illness, of course, is the pointy end of distress, and I personally prefer the term psychological distress. The purpose behind this video is to lead into how and why people can experience escalations in their distress state, and how a crisis can occur, how people can recover from a crisis, or what a lot of people refer to as a breakdown, and how they can build resilience and prevent breakdowns occurring in the future. The final video in this series is going to be what is referred to as mental health first aid, right? The videos needed to be split up because it's actually quite a large subject and there's a lot of content. Um, and I wanted to make sure I gave justice, at least in an introductory manner, towards the content. So, just a reminder, anything that I put up here, it's a case of um, it's up to you. You must do your own research. I'm providing you certain information, but life is not one size fits all, and whatever I discuss is not going to apply to all people within any given context. Okay, so hopefully the content will give information to people specifically um, dealing with heightened distress. And in this particular video, hopefully, I'll be able to provide some information on what they can do to help others who experience distress. And this includes carers. Before we do so, though, I would like to invite you to leave your comments and also to outline that there are limitations in what I load onto YouTube and how I can go about it. So, the first limitation, of course, is the fact that we're putting this content up on YouTube. There is limits on using words that start with the letter S, and I believe there is anyway. And I will have to leave you to try and figure out what I mean by that. But let's say it's the extreme end of distress, where it is completed and it is irreversible and cannot be undone. Now, my understanding too that part of this decision is because content that's loaded on YouTube is allegedly being monitored by the World Health Organization, and it's directly related to the prevention of harmful or misinformation being shared with the general public. This is not something I have an issue with. In fact, I endorse this. I believe it's a matter of ethical and moral responsibility, both professionally and personally. Clearly, spiritually, I have the ethos of do no harm. So I have to outline here to you guys that my channel is not verified in regard to my own qualifications, professional ones, and that my public name of Anah is a feather name. Um, and this is to retain privacy and confidentiality around my identity. Now, if anybody asks me from YouTube to provide documentation such as my qualifications, I can certainly do that. Um, and for your information, I started my studies in 2013 within Australia as a response to reports by the World Health Organization on mental illness and recovery. That's just one reason. So I don't have, or rather, I don't believe that there will be an issue with the content that I put up because the way I conduct myself and the way I work with people is already in alignment with the World Health Organization. They did some very radical research back in, I think it was about 2010. Now, I can no longer find this piece of research. It was amazing. It came up with radical outcomes that they actually didn't envisage and they didn't believe it when they saw the results. So they did another trial. They did a second one. Each trial I can't speak, lasted 12 months. So they had to do a second one. So where I'm going with this is basically I started my training at the time in the Australian context as a response by Australian policymakers to the information that was shared by the World Health Organization after 2 years of studies. And they identified that inclusive and collaborative service delivery was the best outcome or led to the best recovery outcomes for people. Now, I can't find this report anywhere at the moment. If you find it, please do pop a link into the comments and I'll put it into the descriptions. But I think the key important factor of this research was that it did make a mention that recovery is enhanced when there is an earlier intervention as opposed to a later one, and when the person was not taking prescriptive medication. Now, that's just information to help you find the research yourself that I'm referring to, because I don't believe that this has been um, redone or disproven. The other key important factor, just in case you're sitting there thinking, well, I take medication, right? The report does not say you should come off your medication, and I absolutely would not advise anybody to come off their medication, certainly cold turkey. There is times when medication or prescriptive medication is essential, and you would not be advised by anybody to come off your medication without medical supervision, and there is reasons for this. It could actually make your symptoms far worse. Remember, anything that we introduce into our body is a chemical. If you take that chemical out, it's going to have what do they call it, ripple effects to the rest of your body. So please, if you are on medication and you want to come off, go and have a chat with your doctor and do it properly. Okay, I'll just move on to the next slide. So, just to establish my credibility here in regard to the content with mental health, is I was trained under these two frameworks. And I've put these up because you can actually access them online. I hope you can anyway. They're in PDF form, and these were the guiding documents that the Australian government gave to all of us workers back in the day when they introduced what's called the recovery framework in a pilot scenario. And it was actually part of a major S intervention, and I was trained because I was working in the outback areas and there was a lot of youth S, especially among Indigenous folk. So they were actually trying to do a prevention there and an intervention going forward. My training under these documents actually became my pathway to university doing a Bachelor of Social Work. Um, So, what else is relevant here? These frameworks are supposed to be applied to all clinical organisations, and while there's a lot of lip service locally, I'm speaking about the Australian context. I say lip service because you will see organisations saying that they practice it, but they don't. And I'm pretty sure that a lot of these managers haven't even read these frameworks, certainly in the West Australian context. And one of my concerns, having worked in the people in the industry, is the dehumanisation of the patients and the caregivers. And that has led me to ask questions why. I am aware of really good clinicians, but I'm also aware that there's a lot of dodgy ones too. Now, I'm sure that there will be many people out there. I'd be very surprised if they haven't had experiences with what I call dodgy service providers, because there doesn't seem, once again, Australian context, there doesn't seem to be any accountability for those people that work outside the parameters of this. Anyway, where I'm going with this is a brilliant person centered framework that focuses on collaborative, inclusive, holistic services where a person is not on their own and where the clinicians should be, well, in fact, a treatment plan should acknowledge one, the person with the illness is the expert of their own life and what works for them. The second most important person of a treatment plan is the carer because of what they bring to the table. Often the person that's ill can't see how things are impacting them because they're impaired. They might not be able to process properly, they might be heavily medicated or whatever. So the carer can give vital information to the treating psychiatrist or clinicians about what's working and what isn't. So important. And the psychiatrist has the expertise to be able to identify and clearly make diagnoses and establish what should be happening in a treatment plan. A really good treatment plan should always include access to services that allow the person to unpack their trauma or emotional pain and process it so that they can just at least put it into context and let it go and live a little more peacefully. But moving along, So this is definitely a bit waffly and egotistical, actually. But hey, that's the way the industry works, as far as I'm concerned. I am a social worker by profession. I did a mature degree, and it was accredited by the Australian Social Work Association, AASW, Australian Association of Social Work. Um, Now, once I completed that, I started doing a Masters of Counselling, and I didn't complete it. I decided not to do my prac because obviously I'm getting a bit older. But anyway, what they talk about in industry is your areas of expertise. So if you've got a degree, then you're said to have expertise in X and Y. Now, clearly, I've got the Bachelor of Social Work. I've also got additional training in these areas that I've put up here: personality disorders, addiction, anxiety, depressive type disorders, and different types of trauma. Now, once again, I need to reiterate this because when we talk about moderating the content on a social platform such as YouTube, my first concerns are, well, actually, you can try and do it, but they're never going to really do a good job of it because we don't have global qualifications, is where I'm going. Just because I'm competent or deemed to be competent to practice in the Australian context, my degrees are not transferable over to the US or to the UK and vice versa. When we travel and go and live in another country, we've got to sit through tests to be able to become professionally accredited there. Now, in my instance, too, I want to make very clear here that although I have been trained to the standard, the last year or two, I actually have decided not to renew my membership with my profession because I actually have no desire to work within the profession anymore. So I've shifted away from it. So I have to let you know that my training, my professional training now, is not up to standard for the profession, and we are expected to when we're retaining our qualification, which is the little number that we put underneath our signatures on letters and that kind of stuff, we are required to do continuous professional development. Now, I'm not doing it anymore, and this is why I say any content that I provide to you, this is introductory, right? It may have been outdated. Now, when it comes to doing research, I will be giving you some information on what you can do in one of the coming up slides. One of the coming up slides. Oh my God, my English is amazing today. Um, but yeah, you'll see more as we go along. And please do, if you are a social worker somewhere and you want to put up here exactly what I've said, support me with this, or talk about processes within your own country, please do. It's all interesting. So, the beauty of that framework that I showed you a couple of slides back is that it is referred to as an empowerment framework. And when we talk about empowerment frameworks, we're talking about supporting people to take the control of their lives and live them in meaningful ways where they can feel in control of themselves, their emotions, their thoughts. And their environment. But it's important to put in here that when we talk about environmental empowerment, we aren't talking about using our powers over other people and trying to force them to do things that go against their authentic self. What we do when we empower people is we help them to learn the skills of healthy decision making so that the person who is experiencing distress can create a healthy living environment for themselves. That's what empowerment means within that context. So, empowerment also includes, when we talk about the empowerment framework, it includes the provision of information and education around topics that can help them to achieve this goal. Now, unfortunately, what happens is that even, we've got this wonderful framework here, but there's very few people trained in it. And for the average person who's experiencing distress, the capacity to access service is severely limited and restricted, and at least within the Western Australian context, services are inundated. And there's really extensive waiting lists to be able to engage with professionals. So, any of the content that I provide here on my channel is designed to be of an interim nature, just to support a person, give some information to them and their families while they wait to get access to the professional services. Um, Sometimes if somebody's having an extreme crisis, it can be very, very difficult for all the people around them if there's no bed space at the hospitals. So the content here is actually designed, and over the upcoming videos as well, is designed to help you and your family members to avoid hospitalisation, to try and intervene before it gets really bad. Now, I do remind you once again, one size does not fit all. There's a lot more to it than that. But anyway, let's keep going. So what I've done here is I've put up a slide of reference materials. Now, as I said before, I've done a degree and I did my studies, and these are the reference and sources in regard to my qualifications that were on the previous slides. uh, that they come to mind straight away, and I can speak to these and I know the people's experience and that kind of thing. And I'm too lazy to go and look for other more current references. So what I will do is I'll give you these as a starting point and explain the benefits, and then you can go and do your research yourself if that's what you're into, and look for content. When we're studying, it's called credible research if the content is less than 5 years or if it's been reviewed in 5 years. So let's say, going back to those frameworks that I'm talking about, they are now 10 years old and they've never been reviewed because our government doesn't have the same commitment, I believe, to mental health. That's my personal opinion being interjected. But what I'm told is that while those documents are 10 years overdue, they are still our peak guiding tools in Australia. But generally speaking, a document like that should be reviewed every 5 years and updates put into it. So, anyway, it's becoming a bit antiquated, but it's still probably the best thing that we have in Australia. Now, these reference points that I've got on the screen, I'm going to speak to them because they tend to update their content more often. And the first one that you see there is called SAMHSA. I believe that's an acronym or whatever. Now, that I found to be an excellent site. I mean, some of these are designed for clinicians, but you can look at these and still learn information from there. This talks about, with SAMHSA, you learn how to identify, um, are you drinking too much? Do you need to make changes? What's a healthy rate? That kind of thing. And then if you decide that you want to come off your alcohol, actually, I'm not quite sure of the way to explain that right now. But if you want to reduce your alcohol intake or your drug intake or whatever, this kind of content actually helps you to work out how big a problem is it and how are you going to fix it and how can your family help you out and that kind of thing. So that's SAMHSA. Now, I don't know anybody there personally, but I do know that's a wonderful website and I believe it's US based. So anybody, I think, can use that. As for the one on the right, Origin is how it's pronounced. That is an organisation, I believe, that was founded by a guy called Andrew Channon. He is incredible. He has won international and national awards for his interventions in the youth S word that I talked about, and I believe he had input into the recovery framework and the pilot project that I worked on to establish whether or not it should be delivered in Australia. I forgot to mention, actually, it proved to be very successful as a pilot project in the remote areas. We call them bush. I was living in the bush. It was very successful. It didn't actually work so well in the city, and I have my own beliefs around that, and I'm pretty sure other people would potentially agree with me. I think it's actually resistance by the clinicians and some questionable psychiatrists, who are very reluctant to share power and allow people to be the experts of their own lives. Fortunately, there are some good ones out there who will actually work by the recovery framework. Okay, Spectrum, moving on. Spectrum is another organisation, Melbourne based. They are committed to addressing symptoms, if you like, with adults. And the guy that runs that organisation, or influences it at least, I may be wrong, okay, when I talk this stuff, I may be outdated now, so please do put comments down if you know. A guy, Professor Satya Rao, amazing gentleman. Um, he is a massive advocate for the rights of people with mental illness and their family caregivers. He's a psychiatrist. He is brilliant. And these two organisations in Melbourne are very successful. You can generally find educational resources online. I'm clicking my fingers. I don't know if you can hear that. Project AIR is another brilliant one, and this speaks to the experiences of people and their families when there's a personality disorder. Project AIR is run by Professor Bryn Grenier. He also is an amazing clinician. He's also a researcher. Actually, the three professionals that I've talked about here, they are. And Bryn, I actually have met all of these guys when I was doing my training. Bryn was part of the panel that released the recovery framework. So they are really committed to seeing people become healthy. So I can't recommend their tools enough. And on Project AIR, if you can access it, they actually have a lot of fact sheets on there that you might find helpful. The NEA BPD is a brilliant tool for both families and people with illness. So that's I can't remember if that's US based or in Ireland, but you can certainly find that online with a lot of information and resources. The Centre for Clinical Interventions here is a really good one. I'm going to dedicate a separate slide to that. So the reason why I'm creating a separate slide for this one is because I consider it so important, especially for people that are spiritual workers. Now, I've mentioned in the past that I was very focused on spiritual and healing, and what I don't think I mentioned was that I would continually get all these cards and messages saying balance, 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 right? And I'd like, oh, yes, I need to balance, right? So I would do what I thought I needed to do. But the whole point is that actually I did not have a balance. It was because I didn't understand unhelpful thinking styles. I wasn't aware of patterns, and I wasn't aware. I've got to say, I thought I was, but it wasn't until I did my training that I realised that actually I had very limited knowledge about these subjects, and it expanded my mind. Now, the Centre for Clinical Interventions actually has a load of fact sheets. It's directed towards the clinicians. It's there as a tool for them to use with their clients, but it's something that can actually be used by all of us for independent use. Actually, we can look at that and we can do self-assessments. We can get their fact sheets and go, oh, I think like that. So it shows you unhelpful thinking styles, especially if you've got what's called catastrophic thinking, which is, something simple happens and you automatically knee jerk to the worst possible outcome. So there's different thinking styles that become problematic in a person's life. So what this website does is provide fact sheets on how you can look at your thinking styles and what you can do to change them, right? So it's part of the pathway of raising personal awareness as well as implementing personal change and improving your life. It's all about empowerment, right? So, as part of adhering to these WHO parameters, if you like, of providing credible resource stuff, right? That's been the previous slides, and it remains relevant here, is because organisations like WHO are very focused on evidence based and research. I'm not going to go into that there, right? What I will just say is mainstream scientists quite often struggle with concepts around religion, spirituality, and faith. And for many years in the last century, they obviously have poo pooed the idea of God and faith and that kind of thing. There's more of an atheist um, group within the scientists, and where actually they can ridicule people because of their faith and beliefs. But where I'm going with this is there is actually now what they refer to as research literature that supports the fact that a person's religion, spirituality, and faith is often vital to their recovery, how well they recover. So I would say that the clinicians need to stop telling people that faith is not important or speaking down to a person because they have a religious faith and they believe in a God. Because my attitude is if it gives a person hope and it's how they retain peace during difficult times, then good on that, right? Obviously, um, I have my spiritual faith anyway, but I would never attempt to undermine the faith that another person has. And instead of telling you the whole story of how this came to me, but the business with the hands and the cross, that's actually not my story. It was an experience that I had when I was providing support as an advocate to an Aboriginal lady who was living on the streets. And I say that because her situation was so terrible. She endured so much. But she told me the way she sustained herself was that whenever things were really bad and when she thought everything was lost, she was able to sit down and look at her hands and see the lines across her palms making out a cross. And she said, so every time I feel bad, all I have to do is look in my hands and I've got Jesus in my hands. Now, if that's how she survives and what sustains her when she's got no roof over her head and she doesn't know where her next meal is coming from, then I'm all for it. Just to be clear, my job was actually at that time trying to get her a house and get her off the streets. So it was a sad story, but I think it's beautiful what can happen for people when they have faith and hope. So now that we've got that stuff out the way, let's have a conversation about distress. The whole point of this video series is, you know, most dictionaries will explain distress as an emotional state, inverted commas here, that can be quite extreme, such as anxiety and depressive symptoms. Distress, to an extent, is a normal part of life and will demonstrate why in this video. However, in some instances, distress can be extremely difficult for the person to manage, and in those instances, it can often result in very extreme behaviours and actions. Now, psychologists explain that distress is the unpleasant feelings that people experience where they become overwhelmed, and these feelings can impact destructively on the way a person lives and how they interact with other people. So, when we talk about distress in the way that the psychologists refer to it, which incidentally I do agree with, it's easy for other people to think that distress is simply a thought of, oh, I think I'll become distressed today and I will manifest all these symptoms. It just doesn't happen that way. It's not a conscious decision to wake up and go, okay, I'm going to be distressed, right? There's usually underlying physiological or biological factors that can influence on psychological health. And in fact, in the recovery framework, it states very clearly, if I recall correctly, that all mental health treatments should include a full medical assessment to rule out any physical illness before a mental health diagnosis is made. Right, so it's my position anyway that psychological illness or distress is a physiological condition. It is physical illness. It's just that it doesn't manifest in the same overt ways as other illnesses. And not all physical illnesses manifest overtly either, but they seem to be more accepted by people that, oh, well, it's okay for him to have yellow skin because he's got kidney failure. Whereas somebody perhaps who's got dreadful skin related to substance abuse, it's like, well, there's the judgment associated there. But if we understood that there was a physiological component to the addiction, we might be more sympathetic. It's not a case of actually, let's talk about addiction here. It's very rarely a case that an addict can just go cold turkey off something and there's no problems. And in fact, most people with severe addiction actually need to go into a hospital setting to withdraw from their substances because they actually, yeah, it can be quite hazardous, shall we say. So I'll just move on from that for a moment. Yeah, I just wanted to remind you that everybody's different. It's not one size fits all. Okay. Now, in regard to the comments that I made about the physiology, I welcome your thoughts and stories about this. You may or may not agree with me. I invite you to leave comments. However, if you do disagree, it's just a reminder that this is a social platform. While disagreement is fine, it is important to be respectful. Disagreements actually pave the way to the expansion of the mind and understanding. But I must say that if the comments are disrespectful and constitute personal attacks, I will actually remove them. And I might have to do a video on what a personal attack looks like because so many people are so sensitive these days. They get upset about words that really, actually, that's part of their problem. If they're so easily sensitized to a couple of words, then they might to explore why, because not everybody is being aggressive or nasty when they state a truth. And it's important for all people to remain authentic to themselves and not have to monitor, what is the word? Repress aspects of their personality and deny their authenticity to accommodate the emotional needs of other people. So I think I might have to do a separate video on that one. Anyway, to demonstrate why I believe that mental illness or psychological distress is physiological is for a number of reasons, right? The first thing is, if we think about the fact that somebody with diabetes or whatever has, I'll use this as an example, and I might be wrong with how I explain this because I'm not a GP, put in your feedback, right? But a diabetic has a sugar intolerance, as I understand it. They have to minimize or avoid sugar as part of their dietary problems. They may require medication. They may need to have injections as part of keeping themselves well and healthy. The medicines alter the chemical makeup of their body and allows them to live well, because obviously the symptoms of the sugar intolerance is diminished, shall we say, is a better word. Right. So, in regard to the person with what we call mental illness or psychological distress, it's exactly the same. They go to the doctor who does an assessment, establishes the nature of their symptoms, may prescribe medication, may even prescribe, in some instances, injections of medications. So, what am I going to say here? These wouldn't work. This medication would not work if there was not a chemical element to their condition, which is in their physiology, right? So I realise when I talk about this that there are people who are called anti-psychiatry and anti-medication. Now, I'm just going to remind them that's fine. I think that's great. Okay. But the point is, what is right for one is not necessarily right for all. For some people, it's very important that they have medication and that they continue it and they not disrupt it. And in my experience of providing support to people anyway, those that are heavily medicated generally reach a point of having conversations with their clinicians about having their medication reduced. But this is normally with good family supports around them or just support full stop, and where they're actually actively involved in other things like under the framework of therapy and that kind of stuff. But where I would go back to saying, I do respect and agree to a level with these people that are anti-medication and anti-psychiatry, it is where there is we call it, actually, I'll tell you straight up, in industry, it's referred to as the overuse of chemical restraints, right? And that is the provision, or where people are prescribed really heavy dose prescriptions, which should be a last resort. And basically, if I'm going to be judgmental about it, it is lazy clinicians or people doing the like, oh, we can't afford to provide services. We'll just give them a tablet. Take this tablet and go and lie like a zombie or a vegetable somewhere. Sounds terrible, but I think that it's overused. And I know it's a real big problem and people are trying to fight it. But at the same time, it's very important to acknowledge that there are some times when this is necessary, but it's up to the person to determine. Please, leave your own feedback. So, in regard to the physiology of distress, there's actually two aspects about it. There is the internal and the external. Everything has got layers, really, the way we talk about it. Everything's got more than one meaning. So, the internal physiology can be the body chemistry or the cellular makeup. And to give a couple of very minimal examples here is that most people, I imagine, maybe not everybody knows that if you're vitamin D deficient, that actually impacts, it's evidence based and proven to play a role in depression and the diagnosis of seasonal affective disorder, I believe. And I think in the Northern Hemisphere, where they have very short days, that in winter, that the government gives out vitamin D because they had so many issues of depression, right? So if you work indoors a lot and you get very little sunlight and you think you're suffering from depression, you may actually be vitamin D deficient. So when you go down to the doctor and you present and you say, look, I think I've got depression, I'm experiencing X, Y, and Z, and they go, okie dokie, we'll give you a script. You'd be very wise, I believe, to say, can you please test my vitamin levels as well, and explore things like In fact, do your homework before you go in. See what kind of vitamin deficiencies will impact on your mood. Vitamin D definitely is one of them. If you've got low melatonin levels, you will experience insomnia, and things like that. And melatonin is actually vital to it's a vital ingredient of the body, shall we say, because we're all walking around as really just flesh and bone beakers of chemicals, really. And if we become low in one vitamin or chemical mineral, then that's going to have a flow on effect to the way the other cells manufacture and that kind of stuff. So we can easily go out of alignment, if you like, just on a physical level. And you would be so surprised. The more I study this, the more I learn and realize actually we must have protein in our diet. I've got a granddaughter that's got PKU. So she actually has huge food limitations, and she is naturally low on melatonin because of this diminished capacity to take in protein. Um, but yes, anyway, so moving on, what other things when we talk about the physiology? Okay, trauma is proven to impact on the brain, right? So that's the neuroscience, and we'll be doing a separate video on this. But overt symptoms of mental illness, and not everybody knows it the same way as if they've got a physical illness, they don't necessarily see what's happening with their body and how other people perceive them. And this is the role of carers, is really good. Okay, if a person has anxiety, then they might start to have the trembling of the hands. Their speech may be compromised. They might start stammering. They might get tongue twisted, or they might speak rapid fire. So, while these are just some examples. I'm not an expert as far as neuroscience goes or anything like that, but I certainly have used the content that I know as a support person and seen really good results. It seems to the content about neuroscience and neuroprocessing and that kind of thing really seems to support a person to be able to recover and to be gentle with themselves and to pace. So I've seen some really, really great results. So I think most people aren't aware that they can recover. What this is why I have to be very careful that I don't minimize those people that continue to struggle. I don't mean to invalidate them, but many people, so sorry about the but, many people can recover and return to a full and healthy lifestyle. Other people may not recover to the same levels as another person. Recovery is a contentious word, apparently, anyway, but they can certainly improve the quality of their life. Okay, so what we're going to do now is have a look at what's going on and why some people would not engage with services, and this is the tragedy as far as I'm concerned. So I'm going to try and keep it brief and be concise, which is very difficult for me to do given that I've done the social work advocacy and I have had to fight for people's rights against stigma and discrimination. And so I've got countless stories. I'm sure you have some. Please let us know in the comments. But anyway, stigma is described in the dictionary as the projection of a person's belief or lack of belief on another person. So it's like, because I am, you must be, or because I think people like you are, then you must be too, right? So we can look at it from a religious perspective, or we can keep it simple, because I'll put my hand up. I've made some mistakes in the past and I've done some really inappropriate things myself. Certainly prior before my training. About 20 years ago, I ended up living next door to some people that apparently had met in a rehab. And because I'd lived in a remote area, I hadn't actually knowingly been exposed to substance abusers back in those days. If it we're going back a long time, if a person did have substance abuse, I guess it was very well hidden. But anyway, my understandings of drug abuse were based on what I'd seen on the TV, and it included things like, and I apologise to people if this is offensive, but we are talking about the beliefs of decades ago, okay? Was that if a person was a drug user, they were a thief, they would steal from anybody, all of this kind of thing. And so stupidly, because stupidly on my part, I turned around and said to this couple, because we got to know each other quite well, and I said, "Is it true, that a drug addict will steal from everybody?" Well, the female was horrified. Absolutely not true at all. She said, "We certainly did steal to support our habits." She said, "But I would never have stolen from my family." Whereas her partner turned around and said, like, "Really? You were a selective thief?" Or whatever. But it became an interesting story. Where I'm going with this is, what appears to be true for one is not true for all. This is so important. Um, the other thing is too, if you don't know, right? So there is the first thing. Don't make assumptions about a person. Ask the questions. The way I handled that was probably not the best, but ask questions. Be sensitive. Turn around and say, "Well, look, I'm not sure. I'd like to understand." Most people are open and willing to have a conversation about sensitive subjects if there is a underlying respect and an ethos of no judgment. Like, I wasn't judging these people. They were good people. The people that I met were good people. They weren't the type of people they'd been in the past. You know what I mean? So I was not judging them. I was seeking understanding. And they were actually really good, because they gave me information that I guess formed and shaped part of the social worker that I became when I ended up working in the field. So that's stigma, right? Me projecting my issues potentially upon another person, where I assume that all drug addicts will do X and Y. All right. Then the other part is discrimination, which is actually judgment. Now, this is the bad one. This is the horrible one. I just need to pause before I go into this, because this is a big subject. Discrimination is where we either directly or inadvertently treat a person differently because of their diagnosis, or because of their behaviour. And the first one that comes to mind for me, based on my training, is that people with borderline personality disorder are actually quite often denied access to services. And I say this within the Australian context. There is a perception by clinicians that they're too hard to work with. Now, if we think about this, right? Oh, and I need to point out here that if a person's got this diagnosis, they are at far greater risk of becoming a completed statistic than any other demographic. There's only about 5 or 6% of the population actually have this disorder, and they are portrayed quite badly in the media. And I think that, when this is just my view, they may be getting them confused with the narcissistic personality disorder, because while people with BPD do often have some traits of NPD, it's a whole different ballgame. But anyway, going on to direct discrimination, this is what that is. When they turn around and say, "I can't work with that group, they're too much hard work," frankly, I find that offensive, because my thoughts are, well, actually, it's not that the person is too hard work. What that clinician is saying, but is not willing to stand up and take responsibility for their own feelings, is that they actually don't feel competent to work with that person, because they don't have their training to work with them, and they're not willing to expand on their own skill base, if you like. They've just made that, and then they project their issues onto the person. "Oh, no, I don't want to do that. They're all too much hard work." No, they're not too hard work. They're too hard for you because you're too lazy. If you could see me, I get really agitated about these kind of things, all right? So that's one way of discriminating. The other way of discriminating is what we call indirect, where we treat a person differently, or we have unreasonable expectations of them to do X and Y. It could be, well, everybody else can do X and Y. Why can't you? Well, I can't do it because I've got a problem with walking, talking, whatever. You know what I mean? And they still want you to do it. That's discrimination as well. What I do find particularly bad is actually the form of discrimination where a person is denied access to the help that they need because of their disability. And one case that I saw when I was working, and it has stuck with me as a bad scenario, and I bet there's 100,000 of them out there, was a lady who had a physical illness and she was being supported. I was not her key worker, but one day I went down to support her because her key worker was away in a psychiatric facility. And look, long story short here, because I'm aware of time, She identified, I managed to establish in my very brief conversation with her that she had been suffering from a very, very painful physical condition for over a year, where staff had been treating her as if she was insane. And I had made an assumption based on conversations in the office as well that this condition that she was talking about was a psychotic delusion because the woman had schizoaffective disorders. But in the 10 minutes that I spent with her in one conversation, yeah, I got back to the office and I sent an email saying she needs to go to the doctor and she needs to have a full examination because it sounds to me like she's got X, Y, and Z. Now, I actually have had the condition that she had, which is why I knew exactly what she was talking about. And I can tell you it was incredibly painful. And that woman had lived with that condition for over 12 months. Oh my God, makes my blood flare just thinking about it. All right, moving on. So, one of the primary barriers for people engaging with professionals is fear of the consequences of getting a diagnosis because of stigma and discrimination and that kind of thing, fear of what people will think because of the guilt and the shame. And some of these fears are valid and some are just really sad barriers, right? Sometimes fear can be helpful. Okay. By that, I mean that there was one person I was supporting. I'm going to give scenarios again. And the clinician came out and said to me, we need the employer's name. This person was actually still working despite being on heavy doses of medication. And she said, we need to know the employer's name because we need to contact the employer and let them know about the medication. This person shouldn't be operating machinery basically, or driving a car. And I thought, oh, as you do. Now, under my training, it's a case of, did you ask him? So I did. I followed my training. I said, have you spoken to this person and established, did you ask them for their employer details? They said, yes, he refused. And my response to that was, well, if he refused, you cannot by any means expect me to answer that question for you because at the end of the day, our relationship is built on trust. What are your concerns exactly? Tell me what they are. And they said, oh, the medication, he shouldn't be driving. And I turned around and said, well, have you gone as part of your duty of care? Have you jumped in a car and allowed the person to demonstrate their skill base to you? They said, no, they haven't. I said, are you aware that this person actually just sat their truck driver's license? And I would think that a person who is trained to, you know what I mean, to license people for the road actually has more authority than I do within that situation. This person's on the medication, they've gone for their license, they've got their license. I said, I've sat in the car with the person while they drive me around town. No issues at all. Why on earth would I contact their employer based on the fact that the prescription medication says on there may be unfit to drive or whatever? You know what I mean? Each case on its own merits. If you're going to wreck somebody's life, at least have the decency to work out whether or not it should happen, right? Because everyone's so different. Okay, so going back to it, guilt is another thing that will block people from accessing services because all the supports, not necessarily clinical ones, support of any kind, you know, they feel like a burden. So many people who have got heightened distress, they start to feel guilty and ashamed of themselves. They feel that they're emotionally needy. And if those people, their loved ones around them, are addressing problems, they start to feel like a burden. So they don't let them know that they're having big problems. And I say it's a shame because that leaves them isolated and alone in their hour of greatest need, if you like. And it's so unnecessary, okay? One of the other barriers that we've established, and there's evidence to support this as well, not a lot because not many researchers will actually research the experiences for carers, but there is enough research out there that indicates that carers also experience hardship. So I understand that the person with the illness does want to protect them a little and not overburden them. But the caregivers in all of the research are very clear that they wouldn't have it any other way. That if the person they care for is unwell and experiencing distress, they love them and um, they would rather obviously have their life hard than to see this person suffer. And I think we really need to reinforce this to people when they're distressed. They are not on their path alone. They have got help there. And as they make the choice to become emotionally independent and to change their life and um, to start the recovery journey, is what it's called, their family is, you know, they're going to be there for them. And they can support them. It's like, if you're walking up the road and you start to stumble, your family's there to help you, pull you up so that you can keep the momentum until you're well enough to walk and stand alone, right? And the thing is that if you have been, even if they've been really emotionally needy in the past, once they make the choice to become emotionally independent, we're talking about a behaviour change here, and they can do it. And the more support they've got to do it, the quicker they're going to achieve their goals. So, guilt and shame and the fear just really are absolute blockers. But anyway, let I'm going to complete this video now so that we can go on to the how to make the changes. We'll have a look at neuroscience and biochemical first, and then we'll go into the how, the strategy, what we need to do, and the mental health first aid. So I shall see you soon, my friends. Thank you for hanging in there and listening to me waffle, because, man, I feel like a waffler. Speak to you soon. Bye.